Yeah, welcome back, guys. People who are attending this module 2, who have already attended module 1, again, welcome back to all of you guys. And those who are attending this module for the first time, let me introduce myself very briefly. My name is Dr. Sumant Krishna, and I am a practicing OMFS surgeon and a cortical implantologist, along with the conventional implantologist also. So today's topic on module 2 is anatomical considerations for basal implants. And before even I go into, so you are seeing a lot of questions actually posed to me, and these were the screenshots sent to me by Dr. Sesh Kumar, where the module 1, whoever have attended the module 1, they had these few questions. So I'm very happy to answer them. But to start with, first let me answer all these questions and then we'll get into the today's module. Because it will be easy. Otherwise, once I finish the module, second module also, again it will be difficult for you to catch up with, right? So first question is, can we do single tooth replacement with basal implants? Yes, very much you can do single tooth replacements with basal implants, not at all a problem. Only thing is that you have to take into consideration that you get a proper torque, right? And whenever you're doing a single tooth replacements, it's always advisable, right, to give a Maryland kind of a bridge, so that it will be, there won't be any chances of derotation of the implant, right? And moving on to the second question, what's the 1% cause of the basal implant failure? Yeah, I do remember this question. I'm expecting this question to come actually, because I said that basal implants have a success ratio of 98 to 99%, right? So 1%, right? The biggest killer, if you ask me, for any failure is complacency, right? So if you put say 1,000 implants or you put 2,000 implants, doesn't matter. Every implant is a new one to you. You have to treat it as a new one. You have to treat it as your first case. Then only the success rate will be more higher, right? So basically most of the times the chances of failure are restricted to the person who is actually performing the surgery, whoever is placing the implant, right? If you don't achieve a proper torque, right, then that implant is going to fail. So most of the cases, the 1% that failure rate will depend upon the clinician who is actually performing the implant surgery. Okay? Now, ill effect if you wait for more than 72 hours. As I already told you, right, within 72 hours, it is no more a choice. It is mandatory that you load it either with a temporary prosthesis or a permanent prosthesis. The reason being that if you want to take the advantage of the osteoblastic activity that happens in the cortical bone, see, because we are actually, when we are actually using the single piece implants or the bicortical or the basal implants, we are placing the active threads into the cortical bone, right? And as I already told you, right, in cases of cancellous bone, what happens that within 72 hours there is an osteoclastic activity, whereas in the cortical bone it is exactly reversal. There is more osteoblastic activity. So if you want to take the maximum advantage of osteoblastic activity, it is always imperative, better that you actually load the implants within 72 hours. Got it? Now, what will happen if the implant goes into the maxillary sinus? See, the first question is, first of all, why it has to go into the maxillary sinus, you tell me. Right? The reason being that if you are applying undue forces, right? If you apply undue forces while screwing the implant into the bone, right? There is a chance sometimes that it might slip into the maxillary sinus and go. Or when this will deal in detail in the surgical aspect anyways. But generally, if at all, if accidentally, if it goes into the maxillary sinus, don't panic first of all. Nothing is going to happen. Hell is not going to break loose, right? Nothing will happen. Just with a lateral maxillary approach, right? You can just, cut open the cortical plate and then slowly you can actually retrieve it, right? Or you can always take the help of an ENT surgeon, do a FS, and then you can actually retrieve the maxillary implant. So nothing will happen if it goes into the sinus. Nothing is going to happen, mark my words. Right. Next is what can be done, how to tackle mandibular canal in the resolved ridges. This is a too early question to ask. Why? The reason being, because this question in detail, I'm going to discuss in the surgical aspects in the module 3, where you will actually learn about the nerve bypass, how you have to do a nerve bypass. This in detail I'm going to explain to you when I'm dealing with the surgical aspects, right? Next, what can be done in bone resorption cases with basal implants after implant loading. Now, if you remember in the module 1, I said the peri-implantitis is zero, I can say, not even minimal in cases of the basal implants, because they are highly polished surfaces, right? So when there is no chance of a smear layer formation, when there is no chance of a debris accumulation, right? So where is the chance of, first of all, peri-implantitis, which eventually leads to the bone resorption? And secondly, right, what is the active engaging area of the basal implant? It is not the marginal bone. It is not the coronal crestal bone. We are actually dealing with more apical, more reliable cortical bone, right? So there is no chance of resorption, even if a mild kind of resorption happens marginally, or the crestal bone, that is not going to affect the success rate of your implant. So don't worry about it, right? Next, coming to the other question, which was posed by Dr. Ravi Chandu, right? What are the chances of cortical bone fracture while loading implants, as cortical bone is dense? Chances of fracture due to compressive forces while loading. Ravi, good question, right? See, let me tell you one thing. Why does a bone fracture, first of all? Have you any time heard that, due to compressive forces, the bone will fracture? No. A bone usually fractures due to torsional forces, not because of compressive forces. Take for example, let us take for example, right? When you're doing third molar surgery, right? Horizontal impacted tooth, right? You want to extract that tooth, right? So we all have this habit of using the crossbar elevators or the T elevators, right? So whenever you are actually giving a rotatory or a torsional forces to take out the tooth, and if you're not giving a proper support to the mandible, right? Because of the torsional forces, there is a chances of the cortical bone fracture, not because of the compressive forces. And mind you, in single piece implants, we haven't seen any cases of a bone fracture because of implant placement. And don't worry, because just like any tooth extraction, where you are putting any kind of an implant, always if you get a high torque, right, retrieve the implant for a couple of turns and then again try to rotate it. Don't force it inside to the bone, right? And whenever you are actually tightening the implant, right, always give a proper support, right? So the proper support, what will happen, it will actually prevent, if at all, if any kind of torsional forces have to occur, this support actually will prevent the torsional forces from fracturing the cortical plate. Okay, got it? Next, do we need to evaluate the density of cortical bone for every case before placement of basal implants? Actually, no, not required, right? A simple OPG is enough. No need to measure the density of the bone, right? Because what happens, whenever you drill, the first drill itself will tell you that whether the bone is of a D1 quality or a D4 quality or a D3 or a D2. Based on that, you can actually decide your diameter of an implant or the diameter of the drill you are going to use. The first drill itself will decide. So no need to go for a sophisticated studies, right? Diagnostic studies like calculating the density of the bone and all, not required at all, right? Next is what? How about the crown dislodgement probabilities for basal implants? Dr. Ravi, a good question again. Um, you tell me, right? What are the probabilities if you're doing an FPD? What is the probability of crown dislodgement? If you're doing a single tooth FPD, let us say for example, you have done an RCT for a crown and then you want to place a crown. You want to give an artificial crown over it, a zirconia or whatever it is. So what is the probability of the dislodgement of the crown? 5%? 10%? Don't know, or it won't dislodge. The same is with the basal implants. See, it is a single piece implant. It is not a screw retained abutment first of all. The abutment is already, comes along with the shaft. It is one piece, right? So crown dislodgement is same, or you can say as good as any other normal crown what you give onto a tooth, an articulated tooth, right? If you take example of a two-piece implants, there is a chance of abutment, because it is a screw retained abutment, right? So there is a chances of dislodgement there, but here chances are very nullified. So don't worry about the dislodgement of the crown in cases of basal implants. Next, how about the aesthetic appearance if used in front teeth replacement? If recession happens, how we gonna cover that? See, it's the same question again. There is no chance of recession first of all, because these are all smooth. These are not. These are extremely polished and smooth surface implants. They are not rough surface implants where there is the chances of recession of the bone because of perimplantitis. Okay, so nothing is going to happen with the aesthetics. You can happily go ahead, no problem. Right? How about its placement and management of the length in a deep bite cases with less occlusal clearance with single or multiple missing teeth? First of all, my question is how you will come to know. Are you doing a single teeth? Yes, okay. Multiple teeth? Okay, fine. As good as you are going to do a denture. Right? And if you are doing a full mouth, right, you can always raise the bite. Not it? Or, in cases of basal implants, right, the first and foremost rule you can ask me if you say that, there should not be any kind of, the anterior teeth should not touch each other first of all. And let us say you are doing a single tooth replacement. You can always place the implant more subcrestally and then you can give that clearance. So that should not be a problem. Okay? So these are the few questions that I actually got. Dr. Sesh Kumar has sent me to discuss with you guys. I hope you got a little bit of an answer. If you still didn't get it, it's okay, no problem. You can again put the questions, right? I'll be able to answer them in the coming module, right? Now today's module, right? Anatomical considerations for basal and bicortical implants, right? So this is a module 2, right? Now, before, why we included this topic here? Because anatomy is the most vital thing. If you're good in anatomy, mark my words, you can actually play with the bone, right? Or you can play with the case, right? So a lot of people, they fear for placing an implant, or to that matter, even for a simple extraction, or sometimes even for giving a small block also, right? Why they fear is because, somewhere in the back of the mind, they fear what vital structure might be there, right? Am I going in the right direction or not, right? See, I can understand, right? I can understand this because, way back, sometime, so many years back, you would have touched the anatomy textbook of, Chaurasia. I studied Chaurasia and Gray's Anatomy, right? That too way back in 96, in my first year BDS, right? So I do understand that, a lot of you people, right, would have studied your anatomy way back so many years back, and I'm sure most of you would have not even touched that book once you came into your clinical practices, right? So because of the lack of anatomical knowledge, most of you guys, or most of the people, or most of the practitioners are actually, scared of doing things, of putting a single implant or a simple, basal implant or a single teeth replacement, forget about the full mouth, even for putting a single tooth implant, I mean single implant also, then they're scared. Why? Because of lack of this anatomical knowledge. So today, what I'm going to, see, I'm not going to take an anatomy class here, right? I will deal with the anatomy of both the maxilla and the mandible, which is actually relevant for you to place a basal or a bicortical implants, or in general for placing any kind of an implant. So that is what we are actually going to deal with today, right? So I'm not going to bore you guys with a lot of anatomy classes and a lot of theory, right? See, my general way of presentation will be very simple. You'll have a lot of diagrams actually which are self-explanatory, right? I'll be just in detail telling you about all the diagrams there. Okay, now first and foremost, right, is the anatomy of the maxilla, right? Now how many of you, right, remember this diagram, right? It is from Gray's Anatomy, right? See, all the images I have taken it from the Gray's Anatomy, right? Because they are beautiful diagrams. You also can have this online pe mil jayega ye, right? So anatomy of the maxilla, first coming and foremost, right? What is the most anterior most part? What is the anterior most part here? What is this? Right? It is anus, you're right. So it is anus, right? So it is anterior nasal spine. Now you might wonder, I am not in a orthodontic class, why I am being told about this anus now. Right? See, there are situations where, let us say for example, if you want to place an implant, right, in 1-1 region or 2-1 region, or sometimes there is a concavity of bone, right? And sometimes both the bucco-palatal is so narrow, bucco-palatal, right? The bone structure is so narrow, right? Sometimes it is very narrow that it will become impossible for you to place an implant. So that time, what you can do is, you can always take the advantage of the ANS, the anterior nasal spine. You can actually place an implant on the other side into the ANS, because anterior nasal spine is a very thick cortical bone. It is nothing but a cortex within a cortex. Okay, so one is the anterior nasal spine. So you can place, right, into the anterior nasal spine. Now moving on from anterior to the posterior, now what is the second area that we have? What is the second area? What is the second area that we have is the canine fossa region. Is the canine fossa region. Now the canine fossa region is nothing but an imaginary rhomboidal structure, or you can say a triangular piece of a bone, right, that lies above, that lies between, actually between the canine and the premolar region. This is the area you cannot miss to place an implant. You can happily place from different directions, right? You can actually place 3 to 4 implants, one like this, one like this, one like this, and one like this. So you can approximately place 4 implants into this thick cortical bone. So you cannot miss this, right? Now you might ask me, what is the anatomical landmark clinically I can appreciate, right? If you see from the corner of the mouth, right, from the corner of the mouth, 1 to 2 millimeter anterior to the corner of the mouth, if you draw an imaginary line, right, that entire zone is your, the canine fossa region. This is the sound bone. So most of the patients, edentulous cases, you will find this bone. Sometimes it might not be present even in the central incisor or the lateral incisor area, right? But this area, you will 100% you will find a lot of bone there, very thick cortical bone. So you can always use that. Okay. Now, moving at further posteriorly. Now, what is this? What is this area? Right? What is this area? You are seeing this area, right? Now, what is this area? What I have dotted in the red marking is the maxillary sinus. You are right, 100% right. Now, See, this is where lot of guys, lot of clinicians, lot of practitioners, they actually fear to place an implant in the maxillary sinus region. Why? As soon as I see the OPG, right? First a patient walks in, right? He wants a full mouth implant. You're so excited. You feel like jumping on the chair that I got a full mouth case now. So you just order an OPG, right? The patient comes with an OPG. As soon as you see OPG, all that excitement drains down. The simple reason being that you see that the sinus is very close. Immediately you think that this case is not for me. So don't worry. Now, if you actually know the structure of the maxillary sinus, which I'm going to explain in a few seconds, right? You will definitely not feel scared of placing any kind of an implant in that region whatsoever, right? Now, all of you tell me one thing. What is, the shape of the maxillary sinus? I know, since I've drawn there, most of you will say it is in triangular in shape, right? Or, some other rhomboidal, some will say rectangular or whatever it is, right? But actually, the shape of the maxillary sinus is pyramidal in shape. It is pyramidal in shape. Now, where is the apex of the pyramid? Where is the apex of the pyramid? It is towards the zygoma. Okay? Now, where is the base of the pyramid? It is towards the nasal bone. Okay? So, where is the roof? Is towards, now if you see, here it is the apex. Here it is the base. Now, the roof is towards the infraorbital rim and the floor is towards the alveolar process. Okay? Now, imagine if at all, if this is a pyramidal shape. I hope you're all of you are able to see. Now, if this is a pyramidal shape, it means what? The two sides, right, they have to meet at an apex, right? Now imagine, please pay close attention to the structure now, because if you're going to miss any single point what I'm going to talk now, you will be at loss. So please don't, whatever the works you have, put them aside. Please focus only here, right? Now, if let us say this is imaginary maxilla, right? Now, what I'm saying is, if it is traveling upward, the two walls are traveling upward, imaginary like this. Now, this entire zone, what is it covered with? See, in the OPG, you might see, right, the pneumatization of the sinus wall or whatever it is. Agreed. But you are seeing only one surface. You are actually seeing only one surface, because it is a two-dimensional image. So my question is, if this is the maxilla and if this is the maxillary sinus, right? Now if it is pyramidal in shape, it is going towards the zygomatic bone, right? If it is going towards the zygomatic bone, it has to meet somewhere, right? So my question is, between this maxilla and the maxillary sinus wall that is actually traveling towards the zygomatic bone, this entire area is filled with what? Is filled with bone of palate, vertical plate of the palatine process. Now you understand? So whenever you are doing an implant, in the cases of the first molar or the second molar, or to that matter sometimes, let us say in the second premolar region where there might be pneumatization of the sinus, a simple technique for placing an implant in those regions is that you have to approach it more palatally, right? So let us say, for example, if this is a thing, right, this is a buccal side, this is a palatal side, so don't go straight. You have to just go into a palatal direction like this, so that you are taking the maximum advantage of this bone. And single piece implant, you can always bend the implant in whatever the direction you want. Okay, so please don't forget this. This is very, 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 very important, because lot of times people get scared by just looking at the OPG, thinking that, boss, I can't do anything here. See, even I was like that. I'm not saying I was, I was a superhero that, just as looking at the initial days, looking at the OPG, I said I will do it. No. Even it was taught to me by my teachers, and lot of clinical practice what I have underwent. So in my own experience, what I'm telling is, just imagine this. So never forget this point. If it is pyramidal in shape, it has to go and meet at the apex, right? So this part of the bone between the maxilla, right, is the vertical plate of the palatal process. You have a sound bone there. Okay? Got it? Right? So, and if you come into the maxillary sinus, you can take the advantage. You can take, now if you see in the OPG, right, you will find this structure actually. This entire half, right? This is called the posterior wall of the maxillary sinus. Just behind this structure, you will find the posterior wall of the maxillary sinus. So don't be hell bent upon that, एक full mouth case आया है, I have to do pterygoid implant. Not mandatory all the time. You can put into the posterior wall, as there is a thick sinus, there is a thick posterior wall in the, adjacent to the maxillary sinus. You can actually put 2 implants in that. So don't forget this. In the OPG, you will see it like this only. Okay? So now moving on more posteriorly. Now what is this brown structure here? These are the pterygoid plates. Now, how to locate them clinically? How to locate them clinically is a more important question all of us have. Okay? Now, see, imagine yourself, now sitting in front of the screens here, right? Imagine yourself, what you have to do is, simple thing, because you will be attending alone, so you can do it for yourself. Yes? Just pass your finger, put it on the hard palate, just pass your finger, slowly move it on to the soft palatal region, then definitely you will find a bulge, you will find a structure, you will touch one structure, that is nothing but is your pterygoid hamulus, this one. You will find this. You will actually feel it. You will actually feel with your finger. From there, once you actually touch that, right? Now let us say I am actually going palatally, right? Palatally. From there, now you are on the palatal side. Move your finger, means slightly slide your finger towards the buccal aspect. Just 2 mm. Just 2 mm, slide it towards the buccal aspect, and then take your finger superiorly 3 to 4 mm. That is your medial pterygoid plate. Okay, that is your medial pterygoid plate. So once you know the location of the medial pterygoid plate, see, lateral pterygoid plate we cannot feel. So once you know the location of your medial pterygoid plate, so what happens is, right, placement of an implant to put into the pterygoid region, it will be easier. Now, you might ask me, am I going to place an implant? Am I going to place an implant into the pterygoid plates? No way. No way. Right? You are not actually putting an implant into the pterygoid plates, either the medial or the lateral pterygoid plate. You are actually putting an implant into the tubero-pterygoid junction. Okay? You are actually putting an implant in the tubero-pterygoid junction. This entire area, you are actually going to put an implant. If this is the pterygoid process, in this junction you are actually going to place 1 or 2 implants, depending upon the necessity. Right? Now you might ask me, so what is the this anyways, I will discuss in the surgical aspect how to place a pterygoid implant. Okay? But remember, always remember that most of the cases, if it is a freshly extracted case, the pterygoid bone is always located superiorly. It's always located superiorly. when relation to the tuberoid. When relationship to the tuberoid, now I'll just show it to you pictorially. Let us say if this is your tuberosity, your pterygoid is always located somewhere here. So it is always located superiorly. So whenever you are placing a pterygoid implant, your drill actually should be approximately 35 to 40 degrees in a superior direction when compared to the ridge. So like this. So this angulation should be approximately 35 to 40 degrees if you really want to target the tubero-pterygoid junction. Right? And one more important thing what you have to note down is the pterygoid plates are always situated invariably. Right? I'm sorry. If there is a long-standing edentulous case, see this, the superior position of the pterygoids, right? I explained to you in a recently extracted cases or in an individual. But if there is a long-standing edentulous case, say for example 65 to 70-year-old, right? What will happen? Because of the resorption of the maxilla, almost they will be at the same level. Both the tuberoid and the pterygoid plates will be almost relatively at the same level. So that is the reason always clinical palpation is very, very, very important. Got it? Fine. So moving on, next, the pterygoid plates are always attached at an angle with the tuberoid. They are not in a straight line like this. They are not, now imagine, now this is the tuberosity. Now let us say this is the maxillary tuberosity. These two are the pterygoid plates. This is a medial and this is the lateral pterygoid plate. So basically they are always attached like this. They are not attached actually in a straight line like this. They are actually attached medially. They are not attached in a straight line. They are actually attached medially. So whenever you are actually planning to place a pterygoid implant, not only the apical angulation of 35 to 40 degrees, even you have to go in a slightly palatal direction. Approximately 5 to 10 degrees, no, palatal direction you have to go. That is when you will actually exactly go into the tubero-pterygoid junction. So if you go too much palatally, what will happen? You are going to hit the medial pterygoid plate. You are going to hit the medial pterygoid plate, this one. Right? Now how to know that? Now if you go too medially, the simple thing that you will come to know is that there will be ecchymosis in the soft palate. Why? From the medial pterygoid muscle will arise. So if you are going too medial or too palatal, what will happen? If you touch the muscle, it will start bleeding. So immediately you will see the ecchymosis in the soft palate. Don't panic, nothing will happen. Just some cold compressions, retrieve the drill immediately, change your angulation and then just go again in the right direction. Nothing is going to happen, don't worry about it. If you are going to go too lateral, what will happen? It might touch the lateral pterygoid plate. Not only that, one more important structure which I am going to discuss in the later slides, you will actually touch the pterygoid venous plexus. Okay? And one more important thing I want to reiterate here, whenever you are placing, see why I said it should be superiorly only 35 to 40 degrees. Now let us say if you are more vertical, what will happen? The chances of you entering into the pterygomaxillary fissure is more, or the pterygopalatine space. Now you might ask me what will happen? There is pterygopalatine ganglion located there. There is a branch of trigeminal nerve. The moment your drill bit goes into that, what will happen? The patient will immediately give a jerky reaction like ah. Okay? So don't do too much of vertical angulation, right? Too much of lateral or too much of medial. You have to just go at a 35 to 40 degree angulation, slightly 5 to 10 degrees in a medial direction. That's it. Okay? These things can be avoided over a period of time. Once you know the anatomy, what is the anatomical structure that is going to be present there, it will be easier for you. So don't, generally it's very rare that you will enter into the, infratemporal or the pterygopalatine space. Nothing to worry. There is no major arteries here first of all. There are only a small twigs of, maxillary artery branches that might come here and there, but nothing to worry about it. Only don't go too lateral that you might hit the pterygoid venous plexus. So be careful of that. So with this, anatomy of the maxilla. Now moving on to the next picture. Now if you see here what I was saying, right, that the pterygoid plates are actually attached at an angle. If you see, if you take this, the maxillary arch, right, if you take this as a maxillary arch, see where they are actually here. So your drill direction should be like this. Your drill direction should be slightly into a middle direction. Is that clear? Great. So next, so this is again maxillary sinus diagram where you can see the maxillary branches of maxillary artery. That is not of much clinical significance, so don't worry. It is little deeper. You are not going to encounter it as long as you actually maintain a proper angulation. Nothing is going to worry. Don't worry about it at all. Okay. Now, next is what? See, this is what the diagrammatic representation what I have already drawn. This is a better picture actually, where you can see the apex lies in the zygomatic process of the maxilla, right? The base towards the lateral wall of the nasal cavity, roof towards the orbital floor, and the facial surface here, and the floor. Okay. Now, this is what we are more interested in, pterygoid venous plexus. Now, pterygoid venous plexus. Now, why it is so important? Because if you go too lateral, if you are missing the angulation, if you go too lateral for placing a pterygoid implant, you might rupture the pterygoid venous plexus. Now, what will happen if at all if I, accidentally touch the pterygoid venous plexus? It is nothing but a confluence of major veins. It is a confluence. Now, if you see here in the diagram, the circle here, it is a confluence of major veins like superficial temporary vein, maxillary vein, retromandibular vein, right? All these major veins. We are actually not bothered even about that also. But you have to be, whenever if you know, what will happen? There will be flow of the blood. Not like an arterial flow. It will be like a smooth flow. Don't panic. Don't panic. Nothing is going to happen. Even if at all, if you accidentally touch the pterygoid venous plexus. But you have to be careful of three little fellows there, right? Those three little fellows are nothing but is your emissary veins. Now you might ask me, what will happen? What will happen if I that emissary veins are there? Why they cause such a huge problem to us? See, any venous flow, or to that matter, any bleeding, it can actually be easily controlled just by giving a cold compression packs. Right? See, when I say compression packs, you have to wait for a certain period of time. Now you tell me, what is the normal bleeding time? Around 3 to 5 minutes maximum. Now what is the clotting time? 5 to 7 minutes, 7 to 12 minutes. Okay, fine. Now, whenever you are actually compressing, whenever there is a bleeding, now you have to wait for the bleeding to arrest. So you have to give that much amount of time. Now we have this habit, whenever we pack it, every 30 seconds we will remove the cotton and see whether it has stopped or not. I know most of you are laughing now because that is what we do. We do in our clinical practices, we do that. Right? Every 1 minute we'll take out, we'll see whether the bleeding is there or not. Right? Please don't do this. Right? If at all, any kind of a bleeding you encounter in your procedures, place a cotton or a gauze. You yourself have to hold it, compress it. Please don't leave it on to the patient's fate. You don't tell them that, write it and keep for half an hour or 40 minutes. No. If you encounter a bleeding, you yourself, don't leave it to your assistant also. You yourself have to hold it, because they don't know the importance of it. And the patient, let us say, right, he is already on anesthesia. He will not have that much amount of sense actually there to hold it tightly. So please, you do it yourself and wait for that stipulated time of 5 to 10 minutes. Then check. If at all, if it doesn't stop, then see where the source of bleeding is. Normally, in any healthy individual, it will stop in 5 to 10 minutes maximum. If still it, then you have to take a blood picture. Then you have to see the clotting factors and all these things. Now, if at all, if you damage the pterygoid venous plexus, the procedure is the same. You have to actually, same, cold compressions. But additionally, if you know that you have damaged the pterygoid venous plexus, immediately put the patient on IV antibiotics and steroids. Why? Because of these small little three fellas, right? Because of these three emissary veins. Now, what is the specific nature of these emissary veins is, any veins generally, what will happen is, they have certain things called as a valves inside them, right? They collect the blood, right, and then get it to the heart. So they have only one way flow. The backward flow is prevented by the help of these valves that are present actually. But in cases of emissary veins, there are no such valves. It is a two-way traffic. It is not a one-way. It is a two-way highway, where idhar se bhi jata hai, udhar se bhi aata hai. So the chances of infection into the midbrain, into the cavernous sinus, it can sometimes lead to meningitis. But these are all rare complications. I am just giving you a knowledge about this because, even if it happens, nothing to worry about it. Just put the patient on high dose of antibiotics and then steroid therapy. It will be subsided. Nothing to worry about it. Okay. So this is the specific thing of the pterygoid venous plexus. Next, moving on, that is about the anatomy of the, brief anatomy of the maxilla, which is actually required for placement of implants. Now, moving on to the anatomy of the mandible. Now, anatomy of the mandible, see, we don't require actually too much of anatomy of the mandible first of all, but it is essential. Now, first let us deal with the buccal and the labial surfaces of the mandible. Now, a simple question to you guys. See, very small tricks I am going to teach you today, right? Which will be very, very, very helpful for you in your clinical practice. Now, any one of you, just guess it, because you cannot answer me here right now, right? But try to guess. I am going to just give you 5 seconds of time. If a scenario where a patient of, let us say, 65 to 70-year-old patient walks into your clinic, long-standing edentulous, and now you are planning for a full mouth implants, cortical implants. Now you will tell me, you have to tell me, where is the location of the second molar? It is an edentulous. Clinically I am asking. Radiologically anyways you can't make out. But clinically, can you tell me where you have to put the implant, assuming that it is the second molar region? Anybody? Guess ho gaya? Okay, I got it. Right? See, now, once you make the patient sit on the dental chair, pass your thumb slowly along the external oblique ridge. Slowly along. Now let us say this is, okay, I'll show it here only. Now let us assume that this is an edentulous case. Now wherever, now you pass along the external oblique ridge, right? Once you pass, wherever your external oblique ridge ends, wherever your external oblique ridge ends will be the area of your second molar. 99.9% of the cases. And this I have done it in my own practice. So wherever the external oblique ridge ends is the area of your second molar. So that is where you have to put your first implant. Lot of people, I have seen them putting the implant in the retromolar region. See, I am not making fun of anybody here. Even I have done that in my initial days, not knowing about this. I have seen people putting in the third molar region, where we generally we don't replace the third molars even by implants also. Right or wrong? So, they put implants in the retromolar region. They put it like this, sometimes thinking that I can bend it, or I can give a customized abutment and then make it into a second. No, the simple trick is wherever your external oblique ridge ends, you have to just feel it. The tactile perception is of very, very, very important here. So wherever the external oblique ridge ends will be the area of your second molar region. Now, second point. Clinically, how can you know that this is the mental foramen region? Radiologically, yes, I know OPG. I have seen the OPG. You all will say that you have seen the OPG. I know, I can understand that. So you tell me. So what my question is, clinically, in a clinical scenario, where will you know that this is the second molar, this is the mental foramen region? Any guesses? Okay, I'll tell you. Now, you all know about the buccal frenum. Have you all heard about this buccal frenum here? Right? Wherever your buccal frenum is attached, that area, most of the cases invariably will be your mental foramen region. So based on that frenum attachment buccally, you can actually plan your implant either mesial or distal to it. But don't worry, I will teach you in the surgical aspect how to place an implant even over the foramen also. So don't worry, without even causing a damage to the nerve. Okay? So this is about the labial aspect. And of course, anterior to the buccal frenum, clinically I am talking about, right, is the interforamen region on the other side to buccal frenum is the interforamen region. Wherever you want to put an implant, you can put it. You can actually place an implant because you have a very thick, the symphysial region between the two canines. There is a lot of bone there. So in wherever, how many implants you want to put, you can you can put it there. Nothing to worry about it. Okay. Now, coming on to the lingual aspect. Of the mandible. Few things what you have to understand here is, right. Now, this is, all of you know that the foramen, right, where the inferior alveolar nerve enters actually. Now, whenever it divides from the mandibular nerve, means the mandibular nerve again divides into two, which is the inferior alveolar and the lingual nerve, right. So this inferior alveolar nerve enters into the foramen, inferior alveolar foramen, and then the lingual nerve, right, will continue anteriorly in a substructure called as a lingual groove here, and then ends up into there is a lingual groove. If you actually see a dried mandible, you can actually find a thin groove kind of a structure where you will see the lingual groove, right. It actually rests in that, approximately 5 millimeters below the alveolar ridge. It is approximately 5 millimeters below the alveolar ridge. So it passes and then innervates into the anterior 2/3 of the tongue. So it supplies the anterior 2/3 of the tongue, not the posterior 1/3. In edentulous cases, you have to be slightly careful, because now if it is a dentist, if it is a dentate case, as in this picture, it is approximately 5 mm below, right? Now imagine this. This is a mandibular nerve which divides again into inferior alveolar, and then this is the lingual nerve. Okay. Now the lingual nerve actually, right, travels approximately 5 millimeters below the alveolar ridge. Now in edentulous cases, in a long-standing edentulous cases, what will happen? Because of the resorption of the alveolar ridge, relatively the lingual nerve will be very close to the remnant of the ridge, residual ridge. So this is what you have to be little careful of. So not only the inferior alveolar nerve, you have to even bypass the lingual nerve also while placing an implant in the posterior mandible. Is that clear? Now it supplies into the anterior 2/3 of the tongue. And next is what is your very important structure next in the lingual surface is your lingual artery, right? Now if you notice this, a small, here it will be approximately, right? Lingual foramen, a kind of small structure will be there, where actually the two arteries from either side will come and coalesce. Where the two arteries from either side, the lingual artery from either side will come and coalesce in the center. So what is the anatomical significance of this is, whenever you are placing an implant, in the anterior mandible, be careful that you are actually placing them in a buccal direction. I mean, it's a labial direction, either straight or labially. Never go lingually. Never place your implant in a lingual direction, because what will happen is, there is a chance, right? Thinking that there is a huge bone, wherever I want to put an implant I can put, because Dr. Sumant told me huge bone is there, you put an implant in whatever. No, you can place a number of implants, no problem in that, but be careful that you are actually putting an implant in the proper direction. You have to put either labially or straight, but not lingual. Because what will happen if you drill lingually, the chances that you might damage the lingual artery, are high. Now, let us say accidentally, I am not scaring you. See, I will give you a scenario, I will give you a solution also. So don't worry. Okay. Now, let us say accidentally, because कोई जानबूझकर नहीं करता है ना, nobody will do intentionally. So accidentally you damage the lingual artery. The moment you damage any artery, it is not like a venous flow, right? Lingual artery, any artery to that matter, if you damage, what will happen? There will be a gush of blood. Sudden sprout of blood, just like this, like a fountain, right? Like a fountain, it will come like this, right? It's not like a smooth river flow, right? It will just like a fountain, it will shoot up over your glasses or your dress or whatever it is, because of the arterial pressure, because it's always a pulsating flow through the arteries. It's not like a smooth flow, right? Don't panic. The first and foremost rule, whenever you are in such a scenario, please don't panic. Nothing is going to happen. The patient is not going to die. Don't worry. So first and foremost rule, even if it is an arterial bleed, what you have to do? Compression. What you have to do is compression. You have to compress it, right? Hold it. As I told you, you have to hold it. Please don't leave it on to the technician or your assistant or to the patient saying that, bite. No. You have to hold it with your own thumb. I know it will pain, but still, it is your responsibility that you hold it in place. And again I said, after every 30 seconds, don't remove the cotton or gauze piece, whatever it is, and keep on checking whether the bleeding has stopped or not. Because whenever you are removing to check the fibers, right, of the cotton fibers or the gauze fibers that are actually in contact with the blood surface, right, they actually again induce bleed. So there is no point. So wait for 5 to 10 minutes minimum. Wait, at least maximum is 12 minutes. You have to wait. Then check for the bleeding. Right? Now, assuming you damaged the lingual artery. You damaged the lingual artery. Okay? Now the bleeding has not stopped. So what should I do? Again, don't panic. Today I am going to teach you a small trick that anybody attending this module can actually do it clinically. And 99% of the times, you can arrest the bleeding. Simply you can ligate it. It's a very simple technique what I am going to teach you today. So if you just follow this technique, right, religiously, means whenever such a scenario happens, it will be very easy for you to arrest the bleed. Now imagine, right, this is my tongue, right, because I cannot show it to you clinically right now. So imagine yourself, you can all, whoever is sitting here who is attending this module, raise your tongue. You see the freedom, right? So I am just going to draw it here so that it will be helpful to you. Now imagine this is your tongue, right? Now there is a frenum attachment right here. There is a frenum attachment you can see on the ventral surface of the tongue, right? The frenal attachment, right? Exactly from that frenum, right, 1 centimeter anterior, 1 centimeter anterior to the frenal attachment, from there, exactly anterior 1 centimeter, mark a point, assuming this is a point, right? From that center point, on either side 1 centimeter, from either side 1 centimeter. So now imagine, now this is the ventral surface of the tongue, right? This is a frenum, okay? Now from here 1 centimeter, either 1 centimeter, 1 centimeter here, right? So take a bite from whichever side you like, right? Take a 10 silk. Don't use vicryl or any other material. You can use non-resorbables, but take a heavy gauze one. Take, for example, you can take 10. Now take a bite here, right? Take a bite here and come out here on the other side, 1 centimeter from other side, and just tie it, right? Because your lingual arteries are actually traversing in this direction only. They come on coeles here. So your lingual arteries actually on the other side will actually get ligated. Most of the cases. Okay? So just tie them nicely. Put nicely 2 to 3 knots. And mark my words, most of the cases you will arrest the bleeding. And this is a simple thing which anybody can do. For this purpose, you don't require a surgeon to come and do. Because you don't have that much amount of time also sometimes. If it still doesn't stop, then invariably you have to shift the patient to the operation theatre. In the meanwhile, just give a tight pack, hold it, then call the surgeon, and then let them do a ligation. Is that clear? So I hope you understood what I meant. So these are the few things which you actually which you have to actually take care of. Okay, great. So next, moving on. See, before even placing an implant, you are supposed to know the resorption pattern of both the maxilla and the mandible. Right? If you want to place an implant, you should know how the maxilla or how the mandible resorbs. Then only you can actually decide the direction in which you want to place an implant. Right? So, if you see the maxilla, it always resorbs in an upward and an inward direction. An upward and an inward direction. Now, if you see the diagram here, it is always in an upward and an inward direction. In an upward and an inward direction. But in cases of mandible, it always in a downward and a forward direction. So the resorption pattern of maxilla is upward and inward direction, whereas the mandible always resolves in a downward and a forward direction. Now, because of this pattern of resorption, it results in a pseudo-classic kind of an occlusion appearance. It actually gives a pseudo-classic kind of an appearance, right? So when it is actually resolving in this direction, now this is like shrinking, this is like expanding. So it will actually give a pseudo-class 3 kind of, an impression. You might think that, oh, this patient is having probably class 3 occlusion. So taking a clinical history is very, very, very important. You cannot just rely on just by looking at the patient, you cannot say that it is a class 3. No. Because of the resorption pattern, right, maxilla is upward, backwards, downwards and forwards for the mandible. So it will give a pseudo class 3 occlusion. So be careful where you are actually taking the clinical history. It is of very, 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 very importance. Clear? Now, and this is how it looks. Now if you see in this image, this is how it actually looks. If you see in a forward and a downward direction. And now if you see the maxilla, how small it has become. Right? It's like a shrunken, it's like a pedo maxilla. Right? But this actually happens. So maximum you can, in such cases, extreme cases, at least try to give an H2H bite. Don't try to give, just because it's like that, don't try to give a class 3 occlusion. It's not going to serve the purpose. Okay, so this knowing about the resorption pattern is very, 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 very important, right? So with this brief, anatomy, right? Now let me move on to the selection of the patient. Now what are the important things? This actually I discussed in the first session itself, in the first module itself, which patients to do, which patients you cannot do. So why again I have covered in this is because these are very, very important points. You cannot forget them. That is why I am just trying to repeat them. Okay. So absolute contraindications are, again I told you, radiation therapy to the jaws, patients who are on biphosphonates or methotrexate, or whenever there is an active pathology. This I discussed in detail in the last module. Now always remember this drug methotrexate, very, 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 very important, because the patients who are psoriatic, they come up, actually they have this, they have this drug in their prescription nowadays. So whenever you come up with this patient, please ask them to get their prescriptions, because these drugs, they have a very reduced osteonal activity. So be careful. Okay. And relative contraindications, I just put it there. Yes, severe smoking, diabetes, because of the systemic reasons. It is not per se because the bone loss will be there, because of the secondary infections or whatever it is. For that reason, we generally noted them in the relative contraindications. And indications you can do in any case, most of the cases, like complete edentulous, patients on full mouth extraction, partially edentulous, single tooth replacement, any clinical case scenario, you can actually go for a basal or a bicortical implants. There is no hard and fast rule that the single piece implants are restricted only for a full mouth rehabilitation. No. In my clinical practice, in my own practice, I have done so many single tooth replacements. No problem at all. Okay. Now this is very important. Now retention points in the maxilla. Now you should always know what is the first case, looking at the OPG or a CBCT. See, most of the cases I don't ask the patient, or I don't burden the patient to go and get a CT scan done. Simple OPG is more than enough for us to actually place a basal implants. We don't require much actually. We don't require CBCT. Okay. Now what are the retention points? You should understand certain terminology. The first thing is what? The first crest and the second crest or second corticals. First cortical or the second cortical. The first cortical is always the crest. The crestal bone is always the first cortical. The second cortical is actually, one is the basal bone, right? And most of you think that the cortical bone is present only near the basal, and this is a wrong concept. This is an utterly a wrong concept. Okay, now I'll tell you why. Now see, always remember, okay, now let us say this is an extraction socket. This is an extraction socket. Okay, now this entire bone is the cancellous bone, or the surrounding bone is the cancellous bone. Is a cancellous bone. Now, most of you think that since the term itself indicates the basal implants or cortical implants or whatever it is, you think that this you have to place an implant till here. No. Okay, exactly. Let us say why I have drawn this picture is because if at all if you're doing a fresh extraction, right? Now if this is the apex of the socket, exactly approximately 3 to 4 millimeters below is actually the cortical bone will start, and it goes on increasing in density, and attains the maximum density near the basal bone. So if you are actually able to place an implant 3 to 4 millimeters beyond the apex, if this is the apex, now what I mean to say is you have to put your threads in such a manner that your threads are engaging here like this, and the shaft actually is here into the cancellous part, and above which is your abutment, right? So this need not be here. So this entire area is the cortical bone, thick mineralized cortical bone. So that is the retention point. Okay, the first retention point actually is the crestal. Okay, and the second retention point is of most important to us, that is within the same parent bone, within the same mandible or within the same maxilla. The retention point will be 3 to 4 millimeters below the apex of the root. That is where actually the thick cortical bone starts. So don't think that it is only located 3 to 4 millimeters at the basal region. No, it starts way above it. Okay, got it? So moving on, so the first crest or the second, so in the maxilla basically, so this is the crest, and this is the, from here, this is the basal, but your cortical bone approximately will start from here. Okay, great. So next, and the nasal spine, as I already explained to you, this is a very thick cortical bone. As I already told you, it is a cortical bone within a cortical bone, right? So this area you can actually use to your advantage whenever you have a concave, both the palatal or a very narrow ridge. So my point was telling you that you can always approach this. From the lateral aspect like this. You can actually put an implant like this into the, you can take the advantage of the nasal spine on the either side like this, and you can always bend the abutment in whichever desired direction you want. You can always bend your abutments in the desired direction. So in this way you can actually give an implants by utilizing the anterior nasal spine. Okay, and the other bones is bone in the floor of the nose. It is also a second cortical, right? this area, right? This entire area you can use. That also you can use to your advantage for placing a basal or a bicortical implant. So don't think that, if the maxilla doesn't have a bone, that we don't have a bone to place an implant. You can always use the nasal floor. Nice cortical bone is there. You can take advantage of it. Okay, in the sinus region only. Even if it perforates into the nasal floor whenever you drill, a pinpoint bleeding might occur. A drop of blood might come out. Don't panic. The moment you place an implant, that itself it will act as a plug. Okay, so nothing will happen. Clear? Next, intrasinusal buttresses. In the OPG I said I'll explain you. Now this is the posterior wall of the sinus, what you will see in the OPG. That is nothing but is your posterior wall of the sinus. Right? So don't be hell bent upon that, I have to place an implant in the pterygoid. Of course, if sometimes the posterior wall is too thin. In the OPG, in this OPG, you have a good posterior wall. You can actually place 2 implants here like this. And you'll get a very good angulation also. Sometimes you don't need to bend also. Right? If you want to put a pterygoid, then your angulation should be approximately like this, going into the pterygoid bone or into the tuberopterygoid junction. So these intrasinusal buttresses, these are all the arrow marks that are there, right? These are all showing you the intrasinusal buttress region where there is a thick cortical bone. You can actually happily place an implants in those regions. Now if you see, this entire area is a canine fossa region. This entire area is a canine fossa region. So don't leave that area. You have to put maximum number of implants into that area. Okay? So these are all the retention points when related to the maxilla. And of course, the tricortical, other than the parent bone. If it is not the maxilla, if it is not the maxilla, then you have to use tricortical. That is the pterygoid bone. This is a pterygoid bone here. See, even if you see here, it is also medially, medially placed. This is the vertical axis, let us say. So here is the pterygoid bone. So they are actually attached at an angle, right? And the other one is what? The zygomatic bone. This we practice, but these modules are actually not for the zygomatic implant. So this we will discuss in the later modules. Okay. These are all the tricorticals. Now retention points in the mandible, there are no tricorticals in the mandible first and foremost. Now here if you see, again same thing, the alar crest is the first crestal bone, the basal bone, that is the second cortical, is the second cortex basically. Now if you see here, right, what I was pointing you to here if you see in the CBCT, from here it actually starts. The thick cortical bone actually, it starts from there. It actually starts from there. So don't think that, most of the cases you fail, right? This I'll tell you in the surgical module. But most of the cases, most of the people fail because they don't engage the second cortex. Most of the implants, they actually restrict themselves only to the cancellous bone. So when it comes to the basal implants or the bicortical implants, you have to go into the second cortex. Otherwise, the chances of failures are manifold. Okay? Now, what is the other retention points? Bone that is caudal to the oblique line on the buccal aspect. Now, what do I mean by saying that caudal? Means below. Again, here also in the mandible, most of the cases will fail if you are actually placing an implant above this line. Most of the people, they put implant only till this level. They put an implant only till this level and think that, मैंने 13 mm का implant डाल दिया या 12 implant डाल दिया, whatever it is, but you are still in the, cancellous bone. Thick cortical bone is present below the external oblique ridge. So you have to make sure that, you are actually placing the implant below the external oblique ridge, not above the external oblique ridge. The moment if you are placing it above the external oblique ridge, it is prone to fail. No matter what, it is definitely going to fail. So please don't do that. Is that clear? Great. And when it comes to the lingual aspect, bone caudal to the mylohyoid line, right? Bone caudal and lingual to the mylohyoid attachment. Okay? Now you all know the mylohyoid ridge, right? Even if you put your finger, you can actually feel, right? You should always make sure, just like what we are making sure that our implant is actually below the external oblique ridge. In the same way, lingual aspect, if you see, your implant should always engage. It should always engage below the mylohyoid line. Now this is the mylohyoid ridge, right? So your implant should actually be here. It should come out here. So it should be below the mylohyoid ridge, not above the mylohyoid ridge. So any implant that is placed either above the mylohyoid ridge or above the external oblique ridge, it is prone to fail. Now understand one more thing. The lingual nerve is actually present somewhere in the lingual groove, here above only. Right? So what will happen if you place an implant, if you try to drill it above the mylohyoid ridge? So the chances that you might damage the lingual nerve again increases. So your angulation should be in such a way that your drill is actually passing below the mylohyoid ridge on the lingual side and the external oblique ridge on the buccal aspect. Is that clear? Alright. Now these are the just diagrammatic representations. Coming to the last aspect, right? Now this picture will actually show you all the green dot, all the green arrow, all the yellow arrows, whatever you are seeing. All the yellow arrows, whatever you are seeing is the first cortex. All the yellow arrows you are seeing is the first cortex. All the green arrows, whatever you are seeing is that is a lingual cortex. LC is lingual cortex. This is a buccal cortical edge or the basal cortex. Okay. So all the green arrows will show the second retention points. Make sure most of the times you have to, not most of the times, all of the times you have to engage into the green arrow marks wherever the lines are given. No, you have to engage into that area. There is no excuse to that. Okay. So here also the nasal floor region, the red color arrows that you are seeing is the pneumatization of the sinus. Most of the times, if you have other bones, you can always avoid, but you can always go palatally, as I explained to you in the sinus region. If you go too much palatally also, it is good, nothing will happen, you can always bend it. And this is the posterior wall of the sinus here. These are the posterior wall of the sinus, these regions. And IFR is the interforamen region where you can actually place implants, as many as you want, but make sure that you are not going in a lingual aspect. Either you can go labially or you can go straight, depending upon your curvature of the mandible. But never go in a lingual aspect, right? The chances of damage to the lingual artery are more. Is that clear? Right. Now, this is one more diagrammatic representation where you can see that the third cortical areas, right? Now this A represents the pterygoid area. This is the nothing but your pterygoid junction basically. A is the pterygoid plates. We are actually going to put an implant in the pterygoid junction region basically, right? B is the zygomatic bone. This is the infraorbital rim area and this is the lateral orbital rim. But here we are not actually putting any implants there per se for the teeth purpose. These are only, D means the lateral orbital rim. These are all for artificial eye replacements and all. These are not used for implants. Just as a diagrammatic representation, I have just shown you now all the areas where you can actually put. So we are actually, in these modules, we are actually concerned morely to the A region, that is into the pterygoid region. Okay? Is that clear, guys? So this was about a brief introduction, or you can say the surgical considerations of for placement of bicortical implants. right? Any questions regarding uh, the surgical aspects, please feel free to post them in the group, so that Dr. Sesh Kumar again will give me all those questions, and I will be able to answer coming in the third module. Whenever it is there, we will let you know priorly. Whenever the third module is there, very soon, because we don't want to miss the continuity, we will also try to plan it, because I'm little busy in this week. We'll let you know the dates anyways, and make sure that this flow is not missing. And regarding the module 1, whatever the questions you posed to me, which I answered, means if you have any queries regarding that, you're free to again pose the questions there. And then so regarding today's module, I hope little confidence I could give you um, regarding the anatomy, that you'll have much more now. That small fear whatever was there in your mind, partly I think I would have taken away that fear from your minds, that at least now you are willing to go ahead and placing the implants. In the next module will be based on the surgery, the surgical planning and all, and definitely we'll let you know about the time. So thank you all of you for all your wonderful time, and for all your patient listening. Thanks a lot.